you very much. Hi, everyone, dear panelists, dear attendees. I'm honored to be moderating today in this session of the Mega Online Academy. Our next speaker is Major General Professor Dr. Nabil El-Askalany. He is a professor of anesthesia, and also he is the president of the Egyptian Society of Anaesthesiologists. Welcome, Dr. Nabil. Thank you for joining us today. He is going to enlighten us about an important topic, which is guidelines for ICU design. I'm reminding you just any questions in questions and answers or in the chats. You can start, Dr. Samir. Thank you for being with us today.
Bismillah ar-Rahman ar-Rahim. I'm extremely thankful and grateful for the introduction, the kind introduction. In the meantime, I would like to express my sincere gratitude to Professor Saad al-Mahdi for his enthusiasm, his perseverance in holding such a course, which is very fruitful and very beneficial, and I hope it will last for a long time. Thanks a lot. As regards my presentation today, it's about guidelines for intensive care unit design. What do we mean by guidelines, or what's our objective from guidelines for obstetric for intensive care units? Our objective is to put guidelines for healthcare professionals to participate in the occupancy and construction of the intensive care. The participants who participate in this are architects, engineers, information technology, apart from healthcare professionals. And our target is to have healing environments. As a matter of fact, these guidelines are performance guidelines more than the prescriptive guidelines, and we'll show the difference during the presentation. The configuration of the intensive care unit differs from one hospital to the other, so it differs in rural hospitals from university hospitals and so on. It's according to the function it serves. Information technology plays a vital role in the new construction of intensive care units, and the families are involved nowadays. Families are involved nowadays in every day in patients within in the intensive care, and they offer better outcome. It's an evidence-based design. Slides. How many zones, the intensive care unit, how many zones does it consist of? In the meantime, we're going to speak about if it's single room or multi-bedrooms is better. The distribution, the medical utility distribution, is the flat wall or the booms better? All these topics shall be highlighted very rapidly. As I said before, our objective is to develop a guideline to help guide healthcare professionals to participate effectively in the design, in the construction, and in the occupancy of a new or renovated intensive care unit. Who are the participants? They are a group of multidisciplinary professionals, designers, architects, with expertise in critical care to offer the optimal design of an intensive care. What's our target or scope is to have a healing environment. Healthcare architects, in the meantime, have more experience in this process. So the recommendations for design of intensive care units, expanding on regulatory guidelines and providing the best possible healing environment. In the meantime, an efficient and cost-effective workplace. As I said before, these are performance guidelines and not prescriptive guidelines. They offer the maximum and not the optimum intensive care. A prescriptive guideline quantifies, as in the case of minimum square footage for a patient room. So the prescriptive is according to the size, while performance guidelines describe the functions that can be accommodated. This document, as I said before, offers optimum conditions rather than minimum requirements. So the intent of these guidelines is to offer a best practice approach as an alternative to the prescriptive minimum standards. And this is according to the budget of the place where it occurs. The configuration and performance of a critical care unit should be driven by the function and place it serves. So it differs from a rural hospital to a teaching hospital. Anyhow, these guidelines are intended to apply to the adult medical or surgical intensive care units, and it should be used worldwide. It's not for a certain country. Experts in information technology should participate along with the architects and engineers involved in construction. Anyhow, these guidelines were written with the intent to be used by healthcare organizations around the world, as I said before. Of whom does the design team consist? It includes multi-professional team members. First of all is the hospital administration, and this is according to the function it serves, according to utilization, and according to the finance and budgets it has got. Secondly, we've got the clinical team, which is a multidisciplinary team. It includes physicians, nurses, infection control specialists, pharmacists, and therapists. So that's the clinical team. So hospital administration, clinical team, in addition to the design team. The design team consists of architects, engineers, whether mechanical, electrical, structural, technology planners for medical equipment and information technology. And the fourth group in the administration of the people who are involved in the construction is the hospital service representatives. So environmental services and even food service participate in this. As I said in the introduction, our goal is to have a healing environment. What do we mean by healing environment, or what are the elements of a healing environment include? First of all, materials and finishes that reduce noise levels. Secondly, they should minimize the glare. They should support infection control. In the meantime, we should have stress-reducing furnishing and decor. And finally, natural light and view of nature. Light is very important for the patients in the intensive care. It offers more privacy. It offers better outcome. As we know, the intensive care unit used to be a black box. The patient never knows day from night. The patient, particularly in multi-bed rooms, suffers from noise, suffers from the patient beside him dies, and this affects his psychological condition. So single rooms is better, and that is why natural light is important. In addition to natural light, you should have views of nature or greens, which is quite important. The optimal ICU design can help both the medical staff and the patient. So it reduces medical errors. In the meantime, it improves the patient's outcome. It reduces the length of stay and hence reduce the cost. It increased social support for the patients, but as I said before, the family participates, staff and patient satisfaction, and finally, it improves staff commitment, and hence the medical errors are reduced. We should have a program or a requirement. We should have functional program is a must during the construction. So if we need isolation categories, if we don't need isolation categories, it will differ. So the need for isolation facilities and how often do we need them? It should be cost effective. In the meantime, development of an infection control risk assessment, evidence-based design allows design teams to benefit accumulated and ever-changing experience of others. The critical care unit consists of 4 major zones: the patient care zone, the clinical support zone, the unit support zone, and finally the family support zone. So the family participates now, as I said before. As regards the patient care zone, the patient care zone consists of patient rooms and adjacent areas. Its primary function is direct patient care, while the clinical support zone consists of functions related directly to patient care and only in patient rooms, but also in other areas, not only in patient's room, but also in other areas of the unit. The unit support zone refers to areas of the unit where administrative materials management and staff support function occur. I'm sorry, just a moment, please. Anyhow, as we said, the zones are 4: the patient support, the clinical support, and then we've got the administrative zone. What do we mean by administrative zone, or what's the target from the administrative zone? It's the place where doctors live. Doctors would like to have a nap, for instance, so they offer better participation in the welfare of the patient. And finally, we've got the family support zone, which refers to areas designated to support families and visitors. What do we mean by design for the future? We should say that an effective intensive care unit design must be flexible. Why flexible? So that you would be able to accommodate changing care practice and advances in technology over the unit's lifespan. So the size and arrangement of the unit, it should be either minimum is 6 beds and the maximum is 8 to 12 beds. Why 6 beds? For reasons of efficiency and economy, and 12 just for reasons of observation. It is to be noted that intensive care units used to be centralized, that we used to have a central station, central monitors, but now due to the advances in information technology, it's decentralized. The traditional design of clinical care units was reliance on a single paper medical record, central monitors, centrally located workstation from which all beds within the unit can be observed. Nowadays, due to the advances of information technology, functions that had been centralized became decentralized. In the meantime, families became more involved in patient care, and in the clinical and unit support zones, the design should reduce the travel distances for the staff, placing what's frequently needed, equipment or materials, as close as possible to the site of use. So they shouldn't travel a long distance. Imagine that's the room for a patient, a single bedroom. The parents are available, and this improves the outcome of the patient. Here, for instance, we used to say it's forbidden to visit the patient except for an hour. Abroad or in certain countries, the patients are available with the patient the whole time. The efficient unit is small enough and large enough in the meantime. What do we mean? It's small enough for care providers to be fully aware of all activities on the unit. In the meantime, large enough to permit efficient staffing. Anyhow, caregivers must be able to observe patients from many points within the unit, whether centralized or decentralized. Can we say that we have an ideal geometry for the intensive care unit layout? No, there's no single ideal geometry. And as it has been said before, it depends upon the function the intensive care unit serves. Concerning the patient care zone, as critical care zone has evolved to integrate families into daily patient care, family needs and care functions must be incorporated into the ICU design. Which is better, single versus multi-bedrooms? Single rooms offer safety, offer privacy, offer better sleep quality. Single rooms are superior to multi-rooms in terms of patient safety. They also enhance privacy. In the meantime, rooms providing full enclosure have been shown to increase the sleep quality. So by all means, single rooms are better than multi-bedrooms, as seen in the screen. That's the single room, and that's the multiple bedrooms. What do we mean by clear floor area? The clear floor area excludes what's fixed room furnishings, excludes the space occupied by the patient and equipment. The clear floor area dimensions must allow for room services that are brought to the bedside, such as portable imaging, echocardiology, transcranial Doppler examination, electrocardiogram, nuclear medicine, and dialysis equipment. So the clear floor area should suffice all this equipment that might be used. In single patient rooms, the area should be not less than 4 feet at the head and the foot of the bed, and not less than 6 feet on each side of the standard critical care bed. As regards the medical distribution system, what is better? The flat wall, head wall configuration, which is more common, or the booms, or that's attached to the ceiling and the ground? There are systems for mounting and organizing electrical, medical gas, and other medical utility outlets. These include either flat or head wall configuration. As I said before, the flat head wall configuration is mounted on the wall at the head of the bed. This configuration is widespread, but in cases of crisis, it is troublesome. It can create problems during a crisis or cold situation by forcing the staff member responsible for keeping the airway clear to step over a tangle of lines, tubes, and cords. As regards the column configuration, vertical column is attached to the floor and ceiling. It's called boom configuration. The boom configuration consists of movable articulated arms They are ceiling-mounted booms, offer maximum flexibility and positioning and accessing medical gas, electrical, and data outlets. So the boom configuration is the best. Accessory shelves and brackets and poles may be mounted on these devices, allowing optimal positioning of all support devices, such as monitors, computer, and communication devices, and intravenous pumps. The use of booms permits maximum flexibility in bed placement. In the meantime, computer terminals should be available in patient rooms for electronic documentation, as that's part of the information technology. The medical gases, the vacuum data, and the electrical outlets, they need to be accessible from each side of the patient bed. They should be arranged to provide enough room for multiple simultaneous procedures. In the meantime, we should attach 50% of these electrical outlets to the hospital emergency power system, so that if electricity failure occurs, the patient wouldn't be affected. As regards the IV pumps, adequate electrical outlets as well as space should be available. Most pumps connect electronically to patient monitoring or data acquisition systems. Concerning the medications needed on a frequent or emergency basis must be readily available either within or near the patient's room. We should have a fridge if he needs drugs that should be remain cold, that should remain cold. So bedside medication should be secure in the meantime, so that it wouldn't be used not in the proper way. And as I said before, a small refrigerator in the patient's room for medications that must be kept cold, or central refrigerator, thus reducing the staff travel. Concerning the supplies, infection control is an important consideration in handling of patient care supplies. Storage for clean and soiled items must prevent cross-contamination between both of them. Concerning the doors, the door system should be wide-sized to permit rapid movement of patients, bariatric beds, equipment, and personnel into and out of the patient's room in the event of a crisis. So they should be wide doors. In the meantime, sliding glass doors increase visibility to the patients. And it has been said that visibility of the patient is a must and is one of the main factors that reduces mortality and morbidity. Concerning windows, natural light is essential to the well-being of patients and staff. They provide the patients with an outside view. They should be preferable to be overlooking a garden. This helps to relieve anxiety and stress, improve care, and enhance patients' comfort, improve patient orientation. So it's very beneficial to the patients. Concerning the patient room furnishings, they should be at a minimum and containing the following: a hospital bed, one chair for the use of the patient, and one additional chair for visitors. It's not a matter of the whole family coming, no, one additional chair only. In the meantime, it should contain soiled linen collection hamper. Imagine that's the single room for a patient. Look, it looks on a view which is lovely. In the meantime, the windows, the daylight, as I said before, it improves the patient outcome. Other things to be contained in the room are containers to collect trash and waste products, containers to collect hazardous waste products such as needles and syringes. Room should include a clock, a calendar, and tag boards. In the meantime, a television and educational or entertainment system. Some people say, why the television? No, it's a must because the patient is almost needs not only television, even an entertainment system. Concerning the clothing and personal effects, secure storage of the patient and family clothing. Family accommodations. Families may be accommodated in a designated family support zone. I said before that the intensive care unit consists of 4 zones, the 4th of which is the family accommodation zone. It should be in or near the unit or in the patient room itself, or a combination of both. And in some places, we've got hotel type suites nearby the hospital in which the patient is concerned, where a family space adjoining the patient room might provide a desk, internet, and telephone access, and secure storage for a limited number of personal items. As a matter of fact, I said in the start, this is the optimum. But in countries or low-income countries, we can reduce these things. As regards the room decor, pleasant surroundings for patients and staff promote increased comfort and in some cases improved outcomes. The color schemes can affect mood and stress levels. In the meantime, scenes of nature in greens and blues have been shown to decrease stress. Pictures and artwork can be selected for patients who are sleeping all the time or who can't move. Selection of images that can be incorporated into the ceilings of bedridden patients, as the ceiling is most often what is seen. So they put images in the ceiling. Temperature control. The patient and the families should be able to control the patient room temperature. As regards lighting, we've got four sources of light. First of which is natural sunlight. This has been shown to cause less stress perceived by the patient, and in the meantime, using fewer analgesics, it improves the sleep quality and quantity. The bright light, both natural and artificial, has been shown to reduce depression among patients. So all this shows the importance of natural sunlight, and that's why we say the intensive care unit should have windows, wide windows looking on a lovely view. Second type of light is artificial light, which is essential for general illumination and for specific tasks. Then we should have high intensity light source for clinical procedures and reading light on each patient bed controlled by the patient. Lifting devices should be available. We can have mechanical lift devices, which could be built into the ceiling, or mobile lifts. Concerning hand hygiene and toilet facilities and fluid disposal, a variety of options are available. Hand hygiene, the presence of both soap and water and alcohol gel systems are required for maximum performance. Sinks should be available in patient rooms, should be placed near the entrance and near disposal systems. 30 years ago, something of that sort, I used to work in the Royal Free Hospital in London, and we used to inquire why after each patient change the gun and they wash their hands. But now we realize why, and that's a must. Sinks in patients' rooms should be placed near the entrance and near disposal entrance. Dispensers for soap should be located near the sink. A paper towel dispenser and trash receptacle should be next to the sinks. In the meantime, sinks should enable hand-free operation, because the food control devices are not recommended because the design and mounting methods for these devices create difficult housekeeping and infection control conditions. So everything is studied in details. Alcohol gel dispensers should be available. The toilets, as a matter of fact, relative few intensive care patients are expected to use a conventional toilet. Exceptions may include patients under observation or before discharge. For bariatric patients, the toilet should be ground mounted. Shared toilets, in the meantime, can be a source of cross contamination. The room design should afford privacy in the use of mobile commode chairs or bedpans for patients who cannot get out of the bed. Fluid disposal, each patient should have direct access to a fixture for disposal of fluids. As regards dialysis equipment, appropriately conditioned water and drain facilities must be provided in case of need for bedside renal dialysis. This is in intensive care where they afford dialysis. Water and drain connections should be separate from hand washing sinks, and sharps and device disposable. There should be large sharp containers. If we've got isolation areas for infectious patients, formal isolation facilities must be available. So we should have negative pressures relative to the adjacent spaces to prevent the spread of airborne pathogens from an infective patient. Negative pressure. In the meantime, we can use positive pressure in the room's handling system to ensure that airborne external contaminants will not enter the room's environment. So we can use negative pressure and positive pressure. As regards the universal precautions for staff protections, like garments and equipment before entering the isolation room. And this way, we finish the patient care zone, which is the first item of the intensive care unit. Concerning the clinical support zone, this include all unit functions related to diagnosis and treatment of the patients. Some of these functions meet immediate or emergency needs, thus they take place within the patient room and adjacent areas, while others may happen elsewhere on the unit of the hospital. Thus, in design, we should consider proximity of this equipment with the patient and ease of access for the staff. Emergency IVO stations are a must. Teamwork areas, as I said, it's multidisciplinary teamwork. So the quality of patient care has been shown to improve when delivered by a multidisciplinary team. The team consists of clinicians, specialists, pharmacists, respiratory therapists, dietitians, and other health professionals. This document uses the term interdisciplinary team center, and they have a site inside the intensive care unit. They should have a central location for supporting team interaction and certain in centralized activities. We should have an imaging room and may be placed around or near the interdisciplinary team center. Concerning physiological monitoring, as I said before, direct visualization is the best way of monitoring. Each patient's face and body position should be easily seen from the ICU corridor or from the ITC. There is a correlation between poor visualization of patients by nursing staff and physicians and patient mortality. So I said direct visualizations diminish the patient mortality. For safety reasons, each patient should be visible from more than one workstation if possible. We should have centralized monitoring or decentralized, it's all the same. The interdisciplinary team center will usually house centralized monitoring devices. New technology, including text messages, allows unique alarms to alert staff. Physiological and patient trend data may be sent to specialists at remote locations in the hospital or elsewhere and detect the result. Thus, robust video observation, physiological monitoring, and communication links must be provided in every patient's room. Concerning documentation and review, studies have documented the benefits of multidisciplinary rounds. They reduce the cost and length of hospital stay and reduce mortality rates. In teaching hospitals, the impact of a large number of people moving through the ICU influences corridor width and acoustic needs. So, as I said before, the intensive care unit in a teaching hospital differs from those in rural areas. Mobile data entry devices such as workstations or on wheels are used nowadays. As regards pharmacy services, they should be readily accessible, relying on hospital pharmacy and not to buy some things from outside. Space in the unit should be designated for point-of-care pharmacist activity and may include a dedicated computer terminal and workstation. Pneumatic tube systems may be used or satellite pharmacists. A place for preparing and dispensing patient medications should be available. Medications room should provide adequate space. It should contain a refrigerator, secure lock system for controlled substances like narcotics, an automated dispensing machine, and cabinets or drawers for stock supplies. In the meantime, proper illumination. So, as I said, the pharmacy, now comes the turn of the laboratory. The laboratory ICUs must have access to 24 hours clinical laboratory services. These can be provided by the central hospital laboratory or a satellite laboratory within or near the ICU. Pneumatic tube systems may be used. So pharmacy, laboratory, imaging, all these should be available in intensive care. Imaging services should be readily accessible to the ICU. The unit should provide adequate storage for portable imaging machines, a reading room with film viewer boxes. Respiratory therapy, a respiratory therapist and space within or near the ICU provides storage of supplies and equipment such as ventilators. Concerning the specialized procedure areas, the patient should be designed to accommodate, the patient room should be designed to accommodate certain imaging or invasive procedures. Areas of specialized medical procedures may be developed adjacent to or near the ICU, such as a cardiac catheterization laboratory adjacent to a cardiac ICU. Emergency equipment and supply, spaces for storage and rapid retrieval of one or more. What are the emergency equipment? Crash cars with emergency life support equipment, difficult airway cart, central venous cart, access cart, fiber optic bronchoscopy cart. The emergency cart should be located in visible globes along a corridor and not behind the doors of rooms, with an uninterrupted power supply so that when you'd like to use them, they would be charged. They shouldn't be stored in a room or behind a door where they may be hard to find in cases of crisis. Concerning the non-emergency equipment, there should be a place for them. Hazardous waste, there should be a place Prompt removal of items from the bedside to a separate location reduces the risk of patient and medical staff personnel. Concerning the patient nourishment, dedicated spaces to provide food, drink, ice for patients with minimal facilities for preparation. Additional nourishment spaces may be provided for family or visitors. Many ICUs place these facilities in or near the family visitor lounge. Unit support zone. The unit support zone encompasses areas where administrative, logistic, and staff support functions are performed. Administrative functions, locations of offices and conference spaces remote from the patient care zone, multi-purpose conference room, audiovisual equipment, internet connections. Housekeeping functions, central or satellite supplies, linen, paper goods, and things of that sort, clean utility workroom, soil utility workroom, and housekeeping like carts and vacuums, buckets, and ladders. The staff support functions. ICU staff members need places to sleep, eat, relax, take care of personal needs, and store their belongings. Telephones or intercoms should link on-call rooms to the ICU. There should be a staff lounge, staff restrooms, and lockers. Finally, the family support zone. Family support has been recognized as a significant factor in patient recovery and reduced morbidity. So it is an important element to be considered. Concerning signage and wayfinding, we should have directional signage, which should be easy to read and multilingual, wayfinding floor patterns, and requests to turn off cellular phones. A family lounge adjacent or near the ICU, environmental considerations, furniture selections, window coverings, exposure to nature, lighting choices can all produce a calming effect. The use of the televisions in public spaces is controversial. Some agree, some disagree. Concerning consultation rooms for private conversations, disciplinary team members and families. So family communications is a must going on with the patient. Better communication between caregivers and families produce higher family satisfaction ratings. Family nourishment should be taken care of, including drinking fountains, a kitchen. Family sleep rooms should be available. Family laundry should be available. Consumer security and access control. Video cameras and visitors. Ideally, it's not telephone only. A dedicated staff should receive visitors as regards safeguarding the patient privacy, curtains and adjustable blinds should be available. Personal health information and display bedside screens or stations protected unauthorized safety technology, barcoding, communications. Communications is a main cause
Hello.
Dr. Nabil, can you unmute your microphone, please? We can't hear you.
Here you are. But there's something wrong with the net. Anyhow, I've almost finished.
Okay. Thank you.
I'll say the conclusion to offer time for the next speaker. The design of the critical care facilities has an impact on organizational performance, clinical outcomes, and cost of care delivery. In the meantime, organizations involved in design and construction projects are advised to engage experienced consultants who will collaborate with the users and make key design decisions on the basis of best current evidence. And thank you very much for your attention.
Okay, well, thank you, Dr. Askalany, for this very comprehensive presentation. And of course, ICU proper design is of paramount importance, not only for the staff, but also for the patient's well-being and management. I have some questions for you. And if you don't mind, Dr. Ansari, after Dr. Askalany, I have some questions for you from the previous lecture. So for Dr. Askalany, from Dr. Vara, he's asking, what is the sufficient space in square feet for infected and clean patient if they are in an open ICU? The sufficient space for infected and for clean patients if they are in an open area, open ICU?
Well, the space is the same for both. It doesn't differ for clean or for isolated patients. It's all the same. But isolated patients should be isolated from the clean patients. The staff should be isolated so that no cross-contamination would occur. And as I said, if we're saying per square footage, it's 4 foot squares at the head and tail of the bed, and 6 square feet on both sides.
Perfect. Another question.
Whether it's a separate room or it's multi-bedroom.
Yeah, perfect. Another question from Dr. Amani. Can we use boom design in a single patient room? Can we use boom design in a single patient?
Yeah, I get you. Well, it could be used, and it has been shown in the picture.
In the presentation.
It could be used.
Yeah.
There is no harm whatsoever. It offers better flexibility, particularly in cases of crisis. But according to the budget of the hospital or the place it's functioning, the wall-mounted is cheaper. So it differs from one place to the other. But I said the best of them is the boom configuration. And it could be used in a single room.
Perfect. Another question also, Dr. Askalany, is it mandatory for all ICU rooms to be negatively pressurized, specifically for COVID patients? And what if we don't have negative pressure rooms for such patients? What can we do? Is it mandatory
in cases of in cases where we've got airborne pathogens? I said this is the optimum, but the minimum. Not all hospitals or not all intensive cares have got negative and positive pressure handling. I said that's in the optimum conditions. But if a minimum condition, no, there's no harm. What can you do?
Perfect. Is there any guidance for the visiting hours for the ICU?
There's no guidance, and as I said, the family accommodation now, they made places whether inside the intensive care unit or in nearby hotels, suites, or outside the intensive care unit. So the relatives of the patient can stay with him as much as possible if it's single bedrooms. There's no harm at all. And when I used to work in the UK, the families used to sleep in the same room. They had suite for the patient, suite, a room for the patient and a room for the parents.
Perfect. Another question from Dr. Fahmi. How does most relation between patient zones and the clinical care zones during treatment of patients? What arrangement between zones? The question is not clear for me, actually. I don't know if you can get it in the right way or not. The relationship between
the
patient
question.
zones and the clinical care zones. I think we have discussed this.
Excuse me once more. Say it a bit slower, please. Say the question once more.
The relation between patient zone and the clinical care zone during the treatment of the patients.
As I said before, the patient care zone is the area in which the patient stays without the table, furniture, and the bed of the patient. And it's only for the care of the patient. The clinical care zone is for the diagnosis, and it's immediately beside the patient's room. It's for diagnosis and for offering the patient the best care. It should be as close as possible to the patient's room. I hope I understood the question.